Good morning, everyone. Welcome to today's episode of PYA's Healthcare Regulatory Roundup webinar series. Today's topic is One Big Beautiful Webinar, Washington Update. We're happy to present today's webinar on this important topic. You may submit questions during the webinar by typing a message into the Q&A pane of the control panel. Also, immediately following the end of the webinar, you'll be asked to complete a short survey and submit any additional comments. Any questions posed during the webinar will be responded to via email after the webinar. We've posted a PDF copy of the presentation slides for your reference in the Resources pane. You can customize your viewing experience by resizing, moving, or minimizing all of the panes within the webinar.net platform. You'll receive an email later today with a copy of the slides and a recording of the webinar. With that, I'd like to introduce our presenters, Marty Ross and Kathy Reep.
Thanks, Jennifer. Good morning, everyone. Appreciate you joining us for One Big Beautiful Webinar, obviously a play on the reconciliation bill, which is now formally known as the One Big Beautiful Bill Act, or how are we going to say it, Kathy? The OBBBA?
OBBBA.
Got it?
And
OBBBA.
for those who think Marty is kidding, if you actually look at the title of the legislation, it is One Big Beautiful Bill Act. It's really there in writing.
We will have the acronym go down in history with us. So OBBBA. Anyway, what we're going to cover.
Have to say that in future webinars.
Exactly. What we're going to cover today is developments in Washington since the last time we were all together on our April 30th webinar. We do typically do healthcare regulatory roundup twice a month, but because of travel schedules and the like, Kathy and I were only able to do this once this month. So certainly we have a great deal to cover because, time has sort of warped itself in DC and seems to be moving much more quickly as things are happening very quickly. And you'll see we have, of course, a top 10 list of topics to discuss. Obviously, we're going to spend a significant amount of time talking about OBBBA, where we are, where it's headed, how it impacts healthcare providers in particular. But we have also identified other topics of interest, which we will ensure that you are aware of these matters and how they potentially impact your organization. So with that, let's start with the One Big Beautiful Bill Act. Let's start at about 30,000 feet. This bill has really three components. It has the tax cuts and credits. So how we're going to reduce the amount of revenue coming in to the federal coffers. It has requirements for new spending that are focused on military and immigration enforcement. And then we have a set of offsets, which are reductions in federal spending, due obviously in part to the reductions in revenue, as well as new spending in military and immigration enforcement. And then the third piece is how much are we going to add to the deficit? The numbers you see here on the screen are what I believe to be based on the most recent Congressional Budget Office scoring, CBO and the Joint Committee on Taxation, because those are the two entities that are responsible for tracking legislation and informing Congress as to the dollar impact of that legislation. CBO focuses on everything except tax revenue. Obviously, the Joint Committee on Taxation focuses on the tax implications of this. So these are the most recent numbers. At least I believe that to be the case. CBO has been publishing updates regularly as the legislation has progressed through the various committees. So we have a series of tax cuts and credits, some of which are the renewal of the provisions from the Tax Cuts and Jobs Act of 2017, some of which are new provisions that were promised as part of President Trump's campaign. I would note for you that some of those new provisions, such as no tax on tips, overtime, or vehicle loan payments, as well as the higher senior standard deduction, all of those would expire in 2028. So those are short-term tax implications. We also have the new KID credit, or the MEGA accounts, as they're referred to, which is the $1,000 account started for each new child born, and then the ability of family to contribute $5,000 a year into that account, and then the specific rules of when the dollars can be removed from that account. So you also have some offsets within the tax provisions, and we'll talk specifically about those that impact the ACA exchange plans, but those also contribute to the offsets for the tax reductions. New spending, again, the details there, kind of about less than about $1/3 trillion in that new spending. And then the offsets, right now at least, the dollar figure is $1.57 trillion in offsets. And what we have are three primary contributors to those offsets: the changes to Medicaid, the changes to the SNAP program, or formerly known as food stamps, and then significant changes to the various student loan and Pell Grant programs in the federal government. And then finally, what's the net impact on the deficit? CBO scores that at $3.3 trillion increase in the deficit over time to 2034. So we are financing more than we are cutting, shall we say, to pay for the tax cuts and credits in the bill. It has been quite a long and winding road to where we are today with the OBBBA. The process started, as you recall, before Easter on April 10, when the House and Senate finally both passed a budget resolution, a reconciliation resolution, which gave directions to the various committees to identify certain either increases or decreases in federal spending. Our particular focus, again, is on the healthcare provisions, meaning we are particularly interested in what the House Energy and Commerce Committee has done. And as a Mother's Day present to us all, the chair of ENC released the provisions regarding Medicaid, as well as other topics within ENC's jurisdiction, on the evening of May 11th. On May 14th, we had the marathon markup at ENC, 26 hours to make really absolutely no changes in the text. And there was a vote strictly along party lines at the end of that 26.5 hours to advance the bill to the Budget Committee. So that gets us to the Budget Committees. All the committees are all fighting their parts of the legislation. It all gets brought together in a single bill. That's where OBBBA was added to as the title of the bill. And the House Budget Committee was set on Friday to bless the bill and move it forward. But that's not what happened. On Friday, we had 5 renegade Republicans who voted no, which ended up defeating the bill moving forward. So we had some behind-the-scenes negotiations on Friday, Saturday, and Sunday, and finally resulted in a late-night meeting by the Budget Committee, once again, where 4 of those 5 chose to abstain, vote present, and 1 changed their vote to yes. So that resulted in the bill being reported out of the Budget Committee. So again, more behind-the-scenes negotiations the last couple of days of Monday and Tuesday of this week, including President Trump going to Capitol Hill and meeting with House Republicans, giving them very stern directions with regard to Medicaid. Don't F ... with Medicaid. And we are still in the process of figuring out what exactly that's going to end up changing. This morning at 1 o'clock Eastern, or midnight here for those of us in Central Time Zone, the House Rules Committee started meeting. This is the last step before the bill actually goes to the House floor, because the job of the Rules Committee is to determine how debate will proceed in the House, and it's the last chance before it goes to the House floor for amendments. Here they are on my phone, line streaming away. They are still working on this in the Rules Committee. They've just finished with testimony. They've just moved to amendments. The minority leader just proposed an amendment to strike the Medicaid and SNAP cuts. And they're discussing that right now. You can imagine how that is going. But we expect that at some point today, rules will get done with the bill. And we may see some changes in the bill as part of rules. We may not. But Speaker Johnson is pushing very, 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 very hard to have a full House vote either today or tomorrow. because the House goes into recess for the Memorial Day weekend. And the last thing the Speaker wants is for anyone to go back to their district before having voted on this legislation and having it off their plate. Why did rules start at 1 a.m.? They've asked the chair that several times, and she has not responded directly to that question. But clearly they wanted to have, they were not going to limit debate on the bill, and so they wanted as much time as possible so it could still get to the floor. That's all well and good. We will have
Marty,
a memorial.
before you go on, didn't the speaker say that they would stay until they voted?
I've not heard that. Did he? I thought he was still
My understanding is they would not adjourn for the Memorial Day recess absent voting.
They're going to get her done, whatever it may be. They're going to get her done. And there's still some provisions of this bill that are in limbo, that the amount of the deduction for state and local taxes, that is still under discussion. It currently sits at $30,000. Apparently there's some discussion about taking up to $40,000. And there's still other issues that are sort of in the negotiation period, stage. But regardless of what happens, we'll have Memorial Day, we'll eat hot dogs, we'll watch baseball, and then we'll come back and watch this all over again in the Senate and see what they're going to do. And Kathy, what was the majority leader saying with regard to the Senate action?
Well, he feels that there's always room for improvement. They can leave their imprint on whatever is done.
So we shall see. But with all that background, let's talk about the key provisions in OBBBA that impact Medicaid and thus directly impact healthcare providers. First, there are work requirements. If you are going to be on Medicaid, you must, and you are between ages of 19 and 64 and not disabled, or otherwise do not meet specified exceptions, you have to be actively working or engaging in community activity and documenting that during the duration of your enrollment in the program. The states are going to be responsible for verifying that an individual meets those requirements at least one full month prior to applying for Medicaid, and then verifying their status, i.e. ensuring that they are working in some capacity every 6 months for them to maintain on Medicaid. This is the way that this is scored. How much savings does this generate is the expectation of how many people this kicks off the Medicaid program. It's not necessarily tied to the number who are on Medicaid that do not work, which is actually a relatively small percentage, about 10%. But it's tied to the red tape involved in this process and how that will result in folks being disenrolled from the Medicaid program. Next up is the delayed implementation of the eligibility and enrollment final rule. These are actually two rules that were finalized during the Biden administration, which were directed to streamlining the process for enrolling and making eligibility determinations of redeterminations in the Medicaid program. All of those requirements will now be delayed through 2035. Interesting here, Kathy, because several states have already worked towards implementing the requirements of this regulation, of these two regulations. So we'll see exactly what happens there. Then requiring states beginning in October of 2027 that they must conduct eligibility redeterminations at least every 6 months on the expansion population. Of course, that's the group that's between the FPL up to 138%, that 90% federal match for that expansion population. We're now going to require the states every 6 months to verify income to continue those individuals on the program. And then provisions that very much directly.
One thing that is huge there is the impact on the individual's taxes if this isn't done and done appropriately.
Exactly. Then the two provisions that most directly impact providers concern provider tax and state-directed payments. Regarding provider taxes, states will be prohibited from establishing any new provider taxes or increasing the rates of their existing taxes. And states will be required to restructure certain taxes to meet specified requirements going forward. So yes, the grandfathered existing provider taxes, but there are going to be some new requirements which may necessitate some restructuring, which then in turn will impact the provider payments tied to those. Regarding state-directed payments, States will be prohibited from adopting any new state-directed payment for hospitals and nursing facilities that would result in those providers receiving payments in excess of Medicare rates. So during the Biden administration, several states moved to what is referred to as average commercial rate for Medicaid providers to increase the amount that they receive in reimbursement to bring them up to either 90% or 100% of average commercial rate, which would be higher than Medicare in many instances. Any future state-directed payments would be prohibited from exceeding Medicare rates to provide any type of either hospitals or nursing home facilities. Some question here, there are several both provider taxes and SDP state plan amendments that are still before CMS. Sort of a question of what's going to happen to those in this interim period, if they're going to move forward with any approvals on those. But obviously, all of these have the effect of cutting Medicaid dollars. And this graphic you see here is from KFF, Kaiser Family Foundation. Their analysis of CBO estimates regarding a one-year impact of the different provisions and how they will reduce Medicaid spending at the federal level. The work requirements is obviously the heavy hitter here, accounting for about half of the savings, but also the stay on enforcement of the eligibility rule, as well as the provider taxes contribute significantly as well. Other Medicaid provisions in OBBBA, these do not have as significant a financial impact, but again, the impact on providers could be significant. Starting with the retroactive coverage requirement. You know today that most state Medicaid programs will pay you looking back 90 days for a person who qualifies for Medicaid. So you have a person who comes in who's uninsured. You go through the process of getting them approved for Medicaid. You know that in most cases, you're going to get paid for services furnished going back 90 days from the date of application. That's now going to be brought to 30 days of the application if OBBBA is adopted as written today. States will now be required to impose cost-sharing requirements on the expansion adults, not all Medicaid beneficiaries, but the expansion adults that have the incomes between 100 and 138% of federal poverty level, though there will still be exemptions in place for specific services and populations, and the copays cannot exceed 5% of family income.
But again, you're administrative burden on the providers.
Exactly. And so where's the secret calculator they're going to give to help us figure out when do we charge this copay for $35? And of course, the requirements, you can't waive them. There are specific provisions that prohibit providers from waiving these copays for this population. Now states will be required more regularly to verify data regarding beneficiaries, specifically contact information, to prevent the instance where an individual is enrolled in two states' Medicaid programs. And so two separate MCOs are being paid to provide care for this beneficiary. So if I live in Kansas and moved to Missouri, why would I ever do that? But okay. But I was enrolled in Medicaid in Kansas. I'm not taken off the rolls. And so my Medicaid MCO continues to receive a capitation for me, but I'm actually living in Missouri and a different MCO is receiving a capitation payment where I'm actively, in fact, receiving services. This would require states to prevent that from happening, as well as preventing payments made for deceased individuals. New provider screening requirements. States will now be required on a quarterly basis to check the exclusions list to ensure that providers have not been excluded from participation in federal health care programs, as well. That's monthly on the exclusion lists, and then quarterly on the death master file. I did not know there was a such thing called the death master file, but that sounds a little onerous. But that's again to prevent that individuals that are deceased from receiving, providers who are deceased from receiving payments under the Medicaid program, preventing fraud in that regard. Erroneous Medicaid payments. The federal government now very closely track state erroneous payment rates because beginning in fiscal year 2030, states will be subject to FMAP reductions if they have excessive payment error rates. And error rates are tied to both making payments for ineligible beneficiaries, so folks that really, in fact, should not have qualified for Medicaid, but you were making payments to them, as well as overpayments made to eligible individuals. So they will calculate those error rates, and it will result in a reduction in the state FMAP as a result of that. They've given themselves a pretty long leeway, understandably, because there's a lot of detail you'll have to work out in the administrative process going forward. Other changes to be which you're aware of, changes to limitations on coverage for immigrants, different types of immigration status, the rules for calculating Section 1115 waiver budget neutrality, which apparently will have the effect of reining in 1115 waivers, a prohibition on payment of Medicaid funds to Planned Parenthood, and finally a prohibition on the use of federal matching funds for any type of gender transition procedures. So with all of that, what's the impact? Uneven is what the impact would be. And there's two different ways you can see that these reductions in Medicaid spending are going to impact states. First, look at it as a percentage of Medicaid spending per resident. On average, it's going to be about 20%, but you can see it's going to be as high as 50% in Louisiana, as low as 7% in Wyoming. Obviously, states that did not expand Medicaid will not be as impacted as significantly because they are already receiving lower Medicaid payments as a result of the program. Second way to look at this is in terms of enrollment in the Medicaid program. How will we see reductions in enrollment? And this is done as a percentage of the entire current enrolled population. Again, significant variation, South Carolina on the low end, Washington State on the high end, with nearly 25% of Medicaid enrollees coming off the rolls as a result of this program. Doesn't take a rocket scientist here. You are going to see a higher number of uninsured individuals. You're going to see lower payment rates as a result of the restrictions on directed payments. All of this, again, is going to be negatively impacting the revenue side of the equation. Specifically, let's take a look at rural hospitals. And as I've been watching the live stream sort of all since, I have to admit, since midnight, off and on, you have heard several folks talk about the impact of the Medicaid cuts on rural hospitals. And it's very real because just our internal analysis here at PYA, looking at 2023 hospital cost report data, we calculate that somewhere in the neighborhood of 73% of rural hospitals are actually on negative operating margins already. And so when you see reductions in revenue, when you see an increase in uninsured care, that's only going to worsen this condition for rural hospitals across the board. Kathy, you want to talk about some good news? Because I'm really depressing myself here.
Now that you've depressed everyone, and I do want to comment on the first bullet. It says delays Medicare dish reductions. It should be Medicaid dish reductions.
How many times did we look at the deck and we missed it? Okay.
Well, and it should be DSH rather than DHS, but that's okay. Marty did the slides. No. But
Kathy was supposed to be proofreading the slides. Okay,
hey,
come on here. I'm sorry.
This is the issue that came about as a result of the Affordable Care Act, where in order to address the large number of individuals who would be insured, they put in place a reduction to the Medicaid disproportionate share program to the tune of $32 billion. And that was to be taken in at $8 billion a year for 4 years, beginning, I believe, around 2014. We have pushed it and pushed it and pushed it. We're pushing it again so that the first $8 billion hit would not come until 2029. Question is, will we ever see this? But I guess they really cannot just say, we're going to wipe this off the to-do list because it would cost money to wipe it off the to-do list. So they just keep pushing it down the road. They have also included a provision that would prohibit Health and Human Services from enforcing the nursing home minimum staffing rules. These have gone back and forth with the courts, but as of right now, this would be not enforced under HHS. There would be a requirement to streamline enrollment processes for out-of-state pediatric providers by 2029. And then also new rules related to the pharmacy benefit managers. Essentially, they would be required to complete surveys related to drug acquisition costs, publication of that survey data, and then other reforms to the pharmacy benefits managers moving forward. Publishing this acquisition cost information could wind up having some negative consequences as well from a provider perspective, but we will see as we move forward. Other provisions that were included, still working on this one, but let's look at the physician fee schedule. We know that we wanted to see legislation even earlier this year address the reduction in the physician fee schedule. Currently, what we have for 2025 is the conversion factor for the physician fee schedule was essentially, we took about a 2.9% cut. So we wind up having some provisions there where the physicians are not getting a boost in their payment. I think it was about 2.83 actually in terms of the numbers. But we do have the concern in terms of the physician fee schedule cut. What the One Big Beautiful Bill calls for is kind of adopting the MedPAC recommendation, the Medicare Payment Advisory Commission, to use the Medicare Economic Index, MEI, and they are looking at the increase in the MEI from one year to the next. And for 2026, they are proposing an increase in the conversion factor equal to 75% of the estimate of the percentage increase in the MEI. That is currently, we're looking at somewhere around a 2.25% increase over the 2025 level. After 2026, they would be essentially looking at the increase in the conversion, the percentage increase in the conversion factor, and having a payment increase equal to 10% of the MEI increase. Still subject to budget neutrality, MedPAC had recommended the MEI minus the increase in the MEI minus 1 percentage point. But here we're looking at 75% of the estimate of the percentage increase for 2026. From the issue of
Kathy, before you move on, just to be very clear on this, what had been the formula had intended in 2027 for a difference between payment increases for those providers that participated in advanced alternative payment models and those that did not. So it was a 0.75 increase for the first group, 0.25 for the other group. That's what would be moving forward. They've eliminated that. So there's no difference in payment for advanced for participation in those alternative payment models. That doesn't mean MIPS goes away. MIPS is still here. You're still going to be a report on MIPS. There's been no reform there on MIPS. Also, as you talk about the conversion factor is only part of the formula because we also have to deal with budget neutrality.
RVU.
So, exactly. And so if there's changes in the RVUs, either because they change RVUs assigned to a particular service or they cover new services, that gets paid for by reallocation of the pie, and that's through the conversion factor. And so that's why, in part, we saw such a dramatic reduction in the conversion factor this year is because of the budget neutrality requirements. So those are still in play. So don't think you're guaranteed that you're going to get this increase based on MEI change. There's still the math involved in ensuring budget neutrality under the physician fee schedule. Oh, sorry.
No problem. And the question, and one of the questions that was raised by MedPAC is what happens when the MEI is negative? Because it could happen.
So you have a negative change. So it'd be 10% of a negative change.
Right.
Interesting.
So, but see, that's why they used minus 1 percentage point. Okay. Under the Rural Emergency Hospital Program, one of the issues that has been since the program began was the opportunity for those hospitals that had already closed to actually reopen and be designated as rural emergency hospitals. So under this particular legislation, they would permit those hospitals with less than 50 beds that closed between 2014 and 2022 reopen as an REH. And basically we'd be looking at a REH would be considered new with specified distances from of the CA to a PPS hospital, subject to reduced facility payments and reimbursement. And there would be implementing regulations addressing ownership, licensure, location, and like that. They did not give us another issue that we really wanted related to REHs, and that is they did not offer 340B eligibility, nor did they offer swing bed reimbursement. Those are the two issues that have really hindered a lot of providers from wanting to be designated as an REH, 340B and swing beds. But now the only thing they have given us is the opportunity to reopen if you're previously closed.
Oops, sorry.
Huh?
I jumped. I'm sorry. Okay, other provisions, other healthcare related provisions in the bill, several on the tax side regarding the ACA marketplace. So these are the offsets within the Ways and Means portion on taxes. And most importantly here is that the bill does not extend the expanded premium tax credits that expire at the end of this year. So folks that have been on the marketplace because of those tax credits and making those premiums affordable, that will no longer be available beginning in 2026. In addition, the bill would institute new eligibility and income verification processes for enrollees. These provisions align with sort of the proposed rule that came out back in March, which seems like 100 years ago, Kathy, but we had those provisions come out about marketplace reform in March. It would roll back income-based special enrollment periods. So you would only have the calendar afforded time in which you could enroll in the program. And finally, the legislation would limit the definition of lawfully present to qualify for premium tax credits, again, addressing immigration status and your eligibility. At the end of the day, the impact of these ACA marketplace changes are probably as significant as the Medicaid provisions in terms of increasing the number of uninsured. So these are obviously provisions we need to be paying attention to. Regarding artificial intelligence, the bill appropriates a whopping...
On that particular issue related to the ACA marketplace, for those states that had the smaller impact under the Medicaid provisions because they had not expanded Medicaid, they are going to be hit harder by these ACA marketplace provisions.
Exactly, because it's the non-expansion states that had the highest enrollment as a result of the premium tax credits, percentage enrollment. The issue of artificial intelligence, there is a whopping $25 million appropriation to HHS, where they will contract with AI vendors and data scientists to figure out how to use AI to recoup payments from providers, and requires HHS to issue a report to Congress on how well this experiment went. So anticipate this is coming forward. Also understand, I should have included this as a bullet point. OBBBA includes a 10-year prohibition on states regulating AI. So no more looking to the state insurance commissioner, hoping that they would limit the use of AI for purposes of prior authorization by commercial payers and Medicare Advantage plans. That was one strategy we were looking at, is to try and reduce this automated prior authorization process. If we're going to make that, we're going to have to make that noise at the federal level, because states under this bill would not be able to regulate AI for up to 10 years. The other concern here is just this is sort of legitimizing, I think, the use of AI in different ways. I mean, granted, CMS is looking at it in terms of pay and chase and using it for chase. The issue is commercial payers are using it on the pay part of that equation and refusing to make initial payments. Finally, changes to tax-advantaged accounts, the new individual coverage health reimbursement arrangements that allows certain employers to give dollars to their employees to purchase products on the exchange, as opposed to sponsoring their own plan. That would increase the use of that, as well as expanding HSA eligibility, which hopefully, as we see greater patient responsibility, increasing the availability of HSA dollars for those individuals to cover them. Whew, Kathy, talk about the Senate.
As Marty mentioned, the Speaker of the House hopes to get this done before the Memorial Day recess, whenever that might happen. For some of us, Memorial Day will be Monday. We're not sure that that will be the case for those in the House. But after we get through the House, then we have to move on to the Senate. So they will take this up sometime after about 2 weeks. Current issue from the Senate perspective is this is not an issue that is subject to filibuster. So we aren't looking at the need for 60 votes. We're only looking at 50 votes to pass legislation in the Senate. However, there are a number of issues that are concerning to the Senate. Medicaid cuts, obviously, big one because of the impact on their states. And remember, senators, we're talking two from each state, where we've got a number of representatives who are looking at their individual districts. When we start looking at Medicaid, at the Senate, we're really talking responsibility for my entire state and recognizing what's going on there. So concerned about Medicaid cuts. Marty had mentioned the state and local tax deduction going from 30 to 40,000. However, Thune has, as the majority leader, has been a longtime opponent of increasing the SALT deduction. So is that something that he's going to attempt to address no matter what happens in the House? Clean energy tax credits, an issue that the Senate will have to take up. Medicare provider payments, will they start adding to this? Thune was quoted this morning as saying there are things the Senate wants to have its imprint on, and quote unquote, I think you can improve the product. We know that site neutral has been an issue in the Senate for a long period of time. Is this where we're going to see some Medicare issues? Because everything we've talked about, other than the physician fee schedule, has not affected Medicare. So the question is, where will that come in? One thing to recognize is under the Byrd rule, essentially under Senate budget reconciliations, each provision must have a you've got to comply with the rules, and that includes that each provision have non-incidental budgetary impact. So recognize that there are rules in the Senate that are going to have to be complied with no matter what the House passed.
Stay tuned.
Yeah.
Right?
Meanwhile, we did have legislation. We did have the president's budget that was released. And so let's just touch base very quickly in terms of what was there. Skinny budget came out on May 2nd. They expect a full proposal released later in the summer. How this is going to interact with what Congress is doing right now, we're not sure. But the main focus of this particular spending proposal really looked at the various agencies, how much money they're going to be getting. So we're looking at a non-defense discretionary spending coming in about 23% less than 2025. The discretionary, HHS discretionary spending, 26% less than 2025. And then we're unclear, where did the DOGE cuts come in? Is this dollars that are being looked at from the president's budget in addition to the DOGE cuts, or does it include them? And then what happens to the decisions that came out from the courts related to the DOGE cuts? The COVID-19 funding grants to the states that were canceled, do those come back? What's going on here? We don't have a lot of information related to the new agencies that have been formulated under the new administration, the Administration for a Healthy America, the offices of the Assistant Secretaries for Innovation, Enforcement, Strategy, and Product Safety. Where is the funding for these agencies? Where will it come from? And then we also didn't have anything addressed in terms of existing agencies, such as the Food and Drug Administration, the Office for Inspector General, Office for Civil Rights, etc. We do have funding reductions for current agencies. We've outlined it on the slide. But Marty, in the interest of time, rather than going through each of these, you can see that we are looking at funding cuts for all of these agencies. But should we go on to your request for comments? We talked on a prior webinar, the one where we talked about the proposed rules for 2026, that there was a request for information related to deregulation initiatives. What causes administrative burden for hospitals? The American Hospital Association has essentially identified that between 25 and 35% of all healthcare spending is related to administrative tasks. The administration is asking, what can we do to relieve administrative burden? This was done under the prior Trump administration. There was some relief, although minimal. But remember that your comments are due by June 11th. Giving you the website here. Look at issues related to streamlining regulatory requirements, reporting that you have to do, duplicative requirements. The American Hospital Association has submitted, I think it was on May 12th that they submitted their comments. They came up with a list of 100 ways to free hospitals from wasteful and burdensome administrative requirements. Take a look at this. I think you will agree with a large number of the issues. I think some of them are legislated as opposed to strictly coming through regulation and guidance. So you need to be careful on those. I think they're all important, but please take a look, and we urge providers to comment on this list of issues.
Yeah, I wouldn't be relying on the AHA to do the job for you. It's far more impactful to the agency to hear it from providers directly. So even if you are echoing a lot of what AHA said, it's very important to have your voice in the debate. A proposed rule, gosh, in all of this legislative discussion, let's talk about a proposed rule published last week addressing Medicaid direct payment provider tax reform. And closing a loophole that CMS believes has resulted in overpayments to, in this case, 7 specific states as they've structured their provider tax. We've included here a primer on Medicaid provider tax, that it's simply the process of a state imposing a tax on providers using the revenue from that tax as the matching dollars to draw down more federal matching funds under Medicaid. It's permissive. It's permitted. It's very right there in the statute. The states can do this, but there are certain requirements that the taxes must be broad-based, uniform across a group, and generally redistributive. That's a word and a half, isn't it? And there are tests that CMS applies to ensure that a proposed tax satisfies these requirements, particularly on the issue of redistributive. There is a statistical test that CMS applies. However, states have, I guess, figured out that that test is very sensitive to outliers. And so they've been able to pass the redistributive test when, in fact, when the tax revenue results in new payments from the federal government, when that money goes back out to the providers, we're seeing that it's favoring certain providers over others. So the idea here in this proposed rule is to address that loophole. Again, rule was published last Thursday. Comments are due by July 14. How the loophole is being closed is, instead of simply stopping the analysis at the statistical test, CMS will go further and say that the redistributive test will fail if any of these 3 conditions are present: that the tax rate is higher for providers with more Medicaid business than others, the state explicitly taxes Medicaid services at a higher rate than non-Medicaid services, particularly taxes that apply to Medicaid MCOs. Several states will impose a higher tax on their Medicaid business, lower tax on their commercial business, for example. And then states exclude providers with high Medicaid volume from the tax base in a way that skews the statistical test. So These are obviously subjective tests, the CMS evaluating the methodology that the states present and having that leeway to say, no, this doesn't satisfy the requirements. Again, this loophole is targeted, for lack of a better term, at 7 states, 5 of which have had their provider tax approved for more than 2 years. So for those 5 states, CMS is affording a 1-year transition period to correct that provider tax. For the 2 that have more recently approved provider taxes that fall in this category, they will have to comply immediately upon the effective date of the final rule. So very short time windows there. In addition, CMS says doing this, making this change now, will prevent other states from doing what these 7 states have done to leverage more federal tax dollars, more federal revenue to increase their Medicaid spend. CMS estimates that solving for this loophole will save $33 billion for the federal government between 2026 and 2030. Also, they anticipate that state spending will decline by $18.8 billion. What does that mean? That means states will cancel provider taxes that they cannot support, and that then there'll be less revenue available and thus decreases in provider payments as a result. Kathy, Innovation Center?
That was you. Make America
okay.
Healthy Again.
Oh, exactly. CMS Innovation Center, a creature from the Affordable Care Act, which is charged with testing alternative payment models within federal healthcare programs. It has a new leader, a man named Abe Sutton, who comes from private equity. He rolled out on May 13th a new strategy for the CMS Innovation Center focused on prevention, patient empowerment, and greater competition, while ensuring that they are protecting federal tax dollars. As you'll recall, back in February, I believe, the Innovation Center announced that they were abandoning or rolling back certain models because they had determined that they were not making financial sense. And they claimed that taking that action would save $750 million to the program, applies similar rules. What caught everyone's attention when this announcement was made by the Innovation Center was that going forward, the Innovation Center would structure their models to always include downside financial risk borne by the participating providers. And they would also expand models now to include Medicare Advantage. Again, the director assured that there would be resources made available to support rural and small providers so that they could continue participation when, in fact, they would not be in a position to otherwise bear financial risk in these programs. Also, we expect that the Innovation Center will be announcing several new models in the upcoming weeks that will be consistent with this new strategy. And many, I will say it, are openly speculating that one of those models is going to be expanding TEAM, that mandatory episodic payment model, to all hospitals, all PPS hospitals, as opposed to that limited 700 that were selected by CBSA. We'll see what happens on that front.
Against the recommendation from various entities as it relates to reducing administrative burden to make TEAM voluntary. Kind of is the opposite effort. Yes,
exactly.
Let's look very quickly at the CMS Fraud Detection Operations Center, something new that we have to look at. On April 30th, while we were doing our last webinar, DOJ and CMS, it was indicated that they are working on a number of program integrity rules, process improvements, and audit tools that have the potential to save over $40 billion a year. Marty already mentioned the issue of AI as it relates to identifying fraud, waste, and abuse. And the response to this announcement basically said that achieving the savings would require an increase in enforcement activity, such as federal agencies. So the question is, who's going to be auditing? Are we going to be focused that this will be done through AI? They want to save $40 billion a year. In the past, in 2024, they were closer to about $10 billion. So how are they going to make $40 billion in savings? CMS has announced that they are going to create a new fraud detection operations center, the FDOC, that will leverage current fraud prevention systems that use AI and machine learning to flag potentially fraudulent behaviors. And they are going to spend money to save money, saying that for every dollar invested in fraud fighting results in $10 returned to the federal health care program. Those of you who have a compliance role, you need to be paying very, very close attention to what's going on here with the new fraud detection operations center and requests that you might be looking at in terms of potential identification of, let's say, overpayments, inappropriate claims, things like that.
On a related note, we have the DOJ memorandum on white collar crime. So we have CMS enforcing through pay and chase, but we also have DOJ pursuing criminal action against healthcare providers for healthcare fraud. There was some hope that the Trump administration would back off white collar crime enforcement, and thus that would include allegations of healthcare fraud. But on May 12, the DOJ Criminal Division published a memo addressing prosecution of white collar crimes in the administration and emphasized that they would be focusing on 10 high impact areas. The first one listed was healthcare fraud and abuse. The others are more along the lines of like drug cartels and the like. So you are not necessarily in great company if you are one of those high impact focus areas for white collar fraud enforcement. Also, as part of that memo, it announced there were changes to the criminal division's enforcement and voluntary self-disclosure policy, specifically intended to streamline self-disclosure incentives and also providing a clearer path to declination. I hate that word. Basically saying we're not going to pursue this action against you. We have belief that you may have committed a crime, but we'll very quickly shut down the investigation. Also, revisions to the criminal division's monitorship policies. If you find yourself having settled one of these cases with the DOJ, you often end up with a monitorship over a period of time. It's very clear from the memo that these are now strongly disfavored, and the DOJ is committed to reviewing monitorships to ensure that they are controlling costs and preventing scope creep within the organization. Let's talk executive orders. And you know what, Kathy? Unless something happened this morning, this is the longest period of time we have gone without an executive order being issued since January 20th. Because the last one issued was on May 12th.
Were you never told that there are things you shouldn't say out loud? You could think them, but
exactly.
The minute you say it,
Anyway, but since we were last together, 2 new executive orders. The first addressing critical medicines and specifically incentives to reshore pharmaceutical manufacturing. It includes both carrots and sticks as strategies. First, to eliminate regulatory obstacles for expanded domestic production. Right now, we assume about 3 to 5 years to open any sort of manufacturing facility in the United States. This intention is to reduce that time by eliminating regulatory requirements that somehow in different ways limit manufacturers from expanding operations. On the stick side, there are directions to FDA to expand their inspections of overseas manufacturing facilities and to pay for those by increasing fees on those facilities imposed by the United States. Both of these have some short-term significant increases in drug acquisition costs that we need to be considering. And of course, bring this all into this issue around tariffs. I mean, the initial imposition of tariffs, what was happening in the beginning of April, had excluded pharmaceuticals. And generally, pharmaceuticals across the board are excluded from tariffs. But we had in mid-April, the Trump administration signaling that there were new pharmaceutical tariffs coming down the pipe. We haven't actually seen any of that yet. And maybe this executive order is the replacement for the tariffs, but clearly there's a strong incentive in the administration to bring that manufacturing back to the United States. The other executive order in play announced on May 12 is the most favored nation pharmaceutical pricing executive order. It's intended to lower pharmaceutical prices using strategies that had been first employed in the first Trump administration. And here we have a two-step process contemplated by this executive order. First, a 30-day deadline which is now running for pharmaceutical companies to electively lower their prescription drug costs. So you have a chance to correct the issue yourselves. If not, HHS is directed to develop regulations that would tie the price federal healthcare programs would pay for pharmaceuticals to the lowest price that company offers those drugs in other countries, i.e. most favored nation pricing. Drug makers don't like this, as you would not be surprised. And lots of statements last week coming out saying that lowering these prices will result in deep cuts in research and development. It's very true. The United States, their higher drug costs are in fact funding a lot of research and development that is done by drug companies, in part because the other countries to which drug companies sell are single payer systems. And so there is only so much that they can spend on drugs. Now, their pie to spend on healthcare programs is only so big. And so in those cases, the drug companies make concessions. In the United States, they've been able to maintain higher prices. So we will see what happens. There's a long way to go on this particular issue. Last but not least, Kathy.
Yes, we had a request for information, an RFI, another one, related to the health technology ecosystem. Interesting concept, the ecosystem here, but the focus behind this RFI was to look at digital health tools and data interoperability. This was published in the Federal Register on May 16th with only a month to comment, comments due on June 16th. The issue that was raised in the RFI by the Assistant Secretary for Technology Policy in the Office of the National Coordinator, ONC, they wanted to look at ideas to increase beneficiary access to digital capabilities to make better healthcare decisions, and also to look at data availability for all stakeholders to improve health outcomes. They wanted to know what needs improvement, what needs to be created, what gaps need to be filled, etc. What data should CMS make available now and how. The whole idea is because this weaves in interoperability, are we looking at tools that should be talking to others across the healthcare spectrum for an individual patient? When they're seeking comments on this, they are reaching out not only to technology developers, but actually to patients and providers and even payers in terms of what would make this better. I looked very quickly at the questions that they're asking, and under patient needs, they ask, what health management or care navigation apps would help you understand and manage your or your loved one's health needs, as well as the actions you should take? And then it also goes on to say, if you had a personal assistant, I love this one, if you had a personal assistant to support your health needs, what are the top things you would ask them to help with? And then how can I take that personal assistant and make them digital? So I feel that we're going to be seeing a lot more apps as a result of this. Based upon what people identify as needs, I can see the technology developers coming in and addressing, creating new tools, new items that will be promoted to the Medicare and other patients.
But Kathy, there's a need for a provider voice here.
Absolutely.
And the adoption of these products is tied to the reimbursement for services. And if you look at the adequacy of reimbursement for care management services and remote patient monitoring, it doesn't get you there. It doesn't, in often many cases, doesn't cover costs. And so we need to be hearing from providers talking about, we want to do this.
There's a whole section specific to the providers. What can CMS and its partners do to encourage providers, including those in rural areas, to leverage approved digital health products for their patients? You're going to have to address this and the need that you need financing in order to cover it.
I think cutting Medicaid and eligibility. Yeah, cutting Medicaid and decreasing enrollment under the ACA exchanges is probably not a good first step in giving providers the funds they need to pursue these different types of technologies. On that note, we are glad you were able to join us today. We will be back for more. Actually, we will not. On June 11th, our colleague Sarah Bowman will be doing a detailed 340B update. But we will be back on June 25th with what we're going to refer to as yet another Washington update. I guess this is not one big, beautiful webinar. We're going to come back more and give you an appropriate update going into the July 4th holiday. But also encourage you all to sign up for our Washington Update newsletter. We're trying to do it on a weekly basis, sort of fill in the gaps from what we do on the webinars. But otherwise, I hope you all have a nice, enjoyable, relaxing Memorial Day holiday.
Thanks to our
Jennifer.
presenters, Marty and Kathy. Please remember to stay on the line once the webinar disconnects to complete a short survey. Later today, you'll receive an email with their contact information and a recording of the webinar. Also, the slides and recordings for every episode of PYA's Healthcare Regulatory Roundup series are available on the Thought Leadership section of PYA's website, pyapc.com. While at our website, you may register for other PYA webinars and learn more about the full range of services offered by PYA. Please remember to stay on the line once the webinar disconnects to complete the short survey and post any additional questions you may have. On behalf of PYA, thank you for joining us. Have a great rest of your day.